Okay, welcome guys to this Edison based MCQ discussion in which we will going to discuss about some of the MCQs purely based from the Harrison chapters on the topic of chronic kidney disease. This will be very much essential for the medicine topic in upcoming exams. Already. So coming to the first question, the question says about 58-year-old hypertensive male who is recently diagnosed to have a chronic kidney disease stage 3B. Staging is usually done based on the albuminuria level as well as the EGFR level. Okay. So stage was found to be stage 3. There are 5 stages as you all know. So it is on the near to the end stage renal disease this patient was having. So question was, which of the following will remain elevated in the patient? Now as you all know, the term itself suggests CKD chronic. Chronic means there is some sort of chronic inflammation is going on, right? Chronic inflammation is going on. So all the inflammatory marker will rise and all the pro-inflammatory markers will rise in CKD and anti-inflammatory marker will decreases. Alright. So this is the basic concept behind this question. So what are the pro-inflammatory marker? CRP, ESR and fibrinogen. Alright. CRP, ESR and fibrinogen are the pro-inflammatory marker and it will rise in case of any chronic inflammation. Any chronic, or even that also in case of acute inflammation also it will rise. Right. Whereas what are anti-inflammatory? Anti-inflammatory is albumin and pituin. So albumin and pituin, these two, right? These two will remain low. Okay. So this is the concept behind this question. As I've said, so which of the following will remain elevated? Remain elevated in this case will be fibrinogen, and as it is a pro-inflammatory state characterized by altered level of acute phase reactant. So elevated level of acute phase reactant, CRP, ESR, fibrinogen, and reduced level will be albumin and pituin. Now coming to the next question, this question says about the causes of CKD. Alright, so which is the most common cause of CKD? Most common cause of CKD is nothing but a diabetic nephropathy. So diabetes being the most common cause. So what is the next most common cause? Next most common cause is glomerulonephritis. Okay, so diabetes followed by glomerulonephritis. Then what is this third most common cause? Third most common cause of progression of CKD is hypertension. Diabetes, glomerulonephritis followed by hypertension. Fourth most common cause is ADPCKD, that is autosomal dominant polycystic kidney disease, and last common cause will be TIN, that is tubulointestinal nephropathy. So cause wise most common is diabetes mellitus. Alright, diabetes mellitus. Same thing again in the chart from the Edison it is given. So diabetic nephropathy, glomerulonephritis, hypertension associated CKD, autosomal dominant polycystic kidney disease, and other cystic and tubulointestinal nephropathy. Coming to this next question, so okay, let's see what this question is asking about. Okay, it says an elderly man who is known case of hypertension, okay, elderly man and uncontrolled diabetes. So we have just discussed these two being the risk factor of progression of CKD. So what is the patient presenting with? Patient is presenting with decreased urine output and facial puffiness. Again, features of CKD is there, and EGFR, estimated GFR using the MDRT equation was found to be 17.3, which is pretty low. Now, according to KDIGO, what is the stage of this question? Okay, this is a very nice one. Main thing you need to get it out from here is like what is the staging of the patient. Alright, to find the staging of the patient. Okay, so staging is based on GFR. Staging is based on GFR and albuminuria. Alright, so if you look to the chart here, there are how many grades according to KDIGO? This is G1, G2, G3, which is again divided into G3A and G3B, G4 and G5. This is based on progressive decline of glomerular filtration G5 is when it is less than 15 ml per meter square. Alright, 15 ml it is G5. Okay, 15 ml per minute per 1.73 meter square is G5. G1 is normal or high. G1 is more than 90. That is almost normal functioning kidney is G1. What is G2? G2 is mildly decreased, that is 60 to 90. G3 is 30 to 60, which is again divided into two groups, G3A and G3B. G3A is 45 to 60 and G3B is 30 to 45. Again, G4 is 15 to 30. Now, this part is not only enough to assess the risks. Albuminuria is also important. Albuminuria is important, and ranges are less than 30 milligram per gram to be normal. 30 to 300 is called as microalbuminuria, which is also classified as A2, and more than 300 is classified as severely increased. Okay, more than A2 is considered as severe increased, which is A3. Okay, so this less than 30 is A1, 30 to 300 is microalbuminuria, which is A2, and more than 300 is severely increased, that is A3. Now, again, a related question from here: more than 3.5 gram per day is also called as nephrotic range proteinuria, and 1 to 3.5 is known as subnephrotic range. Okay. Now, let's coming to the next question. So let's see what it says. It says urine routine study was given of a 54-year-old male. He presented with a 2+ proteinuria. So proteinuria is there and macrohematuria. His BP was raised 170 by 120, and kidney biopsy was done, which demonstrated features of hypertensive nephrosclerosis. So a patient who came with hypertensive nephrosclerosis, that is hypertensive. What is hypertensive nephrosclerosis? It is very simple term. It is nothing but changes of hypertension seen in the kidney. Now, which of the following is not associated with progression to end-stage kidney disease? Okay. So this is about the hypertensive nephrosclerosis. Now, important thing to note is that systemic hypertension can result into permanent damage. In kidneys, about 6% of patients. Alright, in 6% of patients, systemic hypertension can lead to permanent damage in kidneys. Alright. Now, this hypertensive nephrosclerosis is an entity which is very much race predominant. Like, it is more commonly seen in African American, right? It is more common seen in African American, and reason behind this, it is said that it is associated with APOL1 gene mutation, which is also more common in the African Americans. Alright, this APOL1 is a functional gene for apolipoprotein, as well as the name suggests, apolipoprotein L1, which is expressed in the food process of podocyte. That's why mutation in this may result into proteinuria as seen in the question. Okay. Now, other causes, other risk factor involves male gender. Definitely, male gender is a risk factor. Then, smoking is another important risk factor or hypertensive nephrosclerosis. You can just simply remember smoking increases risks of hypertension, so obviously it will increase the risks of nephrosclerosis. Alright. Alcohol at low dose, we know, is protective for cardiovascular diseases. That's why alcohol is not a risk factor. Instead, at low dose is protective for hypertensive nephrosclerosis. Low birth weight, definitely. Why low birth weight is definitely a risk factor? It is said that if at 3 kg birth weight there is around 0.9 million, that is around 9 lakh of nephron each kidney, and when there is 2 kg birth weight, it reduces to 2.25. Alright, so with reduction in birth weight, number of nephron is declining. As the number of nephron is declining, effective GFR will also decline. So obviously, chance of progression of CKD will increase. That's why low birth weight is also risk factor. What are other risk factors? Other risk factor is there is any pre-existing renal injury. Alright. Same thing again here. Hypertensive, nephrosclerosis, age, male gender, race, smoking, hypercholesteremia, duration of hypertension, low birth weight, and pre-existing renal injury are the risk factor. Now coming to this next question. Okay, this looks interesting. So what is it asking about? It is asking about a 49-year-old female suffering from chronic kidney disease. Okay. So it says 45-year-old female suffering from chronic kidney disease 49 with progressive subcutaneous induration as seen here. Alright. Now it is seen in the arms and legs. She was told that she acquired those conditions due to gadolinium contrast in MRI. The patient should have minimized the exposure at which stage. Okay. This is a nice thing. This thing which we can see here is the feature of dermatological manifestation of CKD, mainly nephrogenic fibrosing dermopathy. Alright, and it is mainly seen due to gadolinium MRI. Okay, so what is the important thing to learn from here? Important thing to know is what are the dermatological manifestation of CKD. Dermatological manifestation of CKD involve most common, which is the most common one? Most common is in the dialysis patient is pruritus. Pruritus in CKD patient can be mainly due to the uremic feature. Now, whenever there is pruritus, don't label directly to the uremic feature. First of all, rule out the common causes like pruritus. For common causes, it can be scabies. Even in the CKD patient, it can be due to hyperphosphatemia. The primary treatment to treat the hyperphosphatemia, treat the other causes, common causes. Treatment of this pruritus also involves giving emollients, moisturizers, or antihistaminics drug. New drugs like opioid kappa agonist have been researched a lot to find whether it is effective or not. Alright. Then this case, that is nephrogenic fibrosing dermatopathy. Now it is due to gadolinium MRI. It is said that whenever there is stage 3, and what was stage 3? Stage 3 is again divided into A and B. Total GFR was around 30 to 60. A is 45 to 60. Stage B is 30 to 45. Alright. In stage 3, minimization of exposure is done. Alright, that is the dosage is reduced. Whereas it should be avoided in stage 4 and stage 5 diseases. Alright. Now, does that mean in CKD stage 5 I will never do gadolinium MRI? No, it doesn't mean like that. Now, if the condition warrants for gadolinium MRI, I should always go for that and followed by dialysis. Important thing to note is that contrast is not dialysable. Contrast is not dialysable. It is not dialysable, but gadolinium contrast can be dialyzed. Okay. Now, same thing again in the explanation part. So abnormalities of skins are prevalent in progressive CKD. Pruritus is the most common one, and it is a feature of the uremic state. In advanced CKD, even on dialysis, patient may become more pigmented, and this is felt to reflect the deposition of retin pigmented metabolites like or eudochromos. So many of the cutaneous abnormalities improve with dialysis because uremia is one of the main sources of these cutaneous abnormalities, but pruritus is often tenacious. So first rule out the unrelated skin disorder like scabies, treat the hyperphosphatemia which can cause itching. And treatment involve local moisturizer, mild topical glucocorticoids, oral antihistaminic, UV radiation, and research studies of kappa opioid receptor have promising effect on reduction in pruritus in hemodialysis patient. Regarding nephrogenic fibrosing dermatopathy, which is as shown in the picture, a progressive subcutaneous induration, especially in the arms and the legs, seen in the dialyzing patient. Source is usually the gadolinium contrast, and current recommendation are that patient with CKD stage 3 should minimize exposure to gadolinium, and those with CKD stage 4 C5 should not even go for the gadolinium induced MRI. Alright.